So an ET tube looks something like this, with the balloon at the end, and the idea being that you want to stick this into the trachea under direct visualization. So when you intubate someone, you have to stop the chest compressions, because you actually have to look in there, and if everything's bouncing up and down, it's going to be hard to find where you want to go. So ideally what you would do is you'd get everything set up while chest compressions are going. When you got your laryngoscope blade in one hand and the tube ready to go in the other hand, or someone's ready to hand it to you, then you say, okay, stop chest compressions. You do a look and you place the whole thing in, hopefully within 10 seconds. So let's say we place this tube in like this, and we make a mistake, and it goes in the esophagus. Now that's going to be a problem, because we're not going to be ventilating the patient. So that's the next question we're going to talk about. How do we confirm placement? So how do you confirm that you got the tube in the right place? Well, let's draw our guy here. You can do it two ways. You can do it clinically, or you can use some kind of device. And ultimately what they recommend, what the American Heart Association, the guidelines recommend, is that you do both, because none of these things are perfect. So get as many confirmatory things as possible. So how do you confirm clinically? Well, one thing you can do is look for chest wall rise with respiration. So you'll see bilateral chest wall movement. That'd be the first thing I would do. Second thing, listen with your stethoscope over the epigastrium. What you're looking for now is you're looking for a whoosh of air. That means you have an esophageal intubation. If you've intubated the esophagus, you're going to hear air in the stomach. The second place, the next place I would listen with your stethoscope is bilaterally on the chest. I'm going to listen there. And what you're looking for is bilateral air movement in the chest. If you've got a tracheal intubation, you would hope to hear it there. So again, look for chest wall rise, listen to the epigastrium, and then listen bilaterally to the chest. I actually like to listen in the axilla, so I can be as far away from the other lung as possible. That way, if I have a right main stem intubation, I'll hear breath sounds over here, and I won't hear them over here. If I put the stethoscope over here, I'm not so convinced that the breath sounds I'm hearing aren't just transmitted from this lung. Technically, these ones will be louder than this ones, but why not just make it easier for myself by just listening there and listening there in the armpits. Okay, and we also talked about using a device. What are the potential devices we could use? There's a couple. One of them is called the colorimetric end tidal CO2 detector. This is that thing that you'll see we attach to the end of the tube and ventilate through it, and it turns yellow and purple with each breath. So yellow and purple, yellow and purple. When you get that color change, you know that you're right. Now you can have some false negatives with this as well. If the patient is in arrest and they're just not ventilating anything at all, you're not going to have any CO2 made from the lungs, and so this color change is not going to happen. Also, severe asthmatics are not going to be moving air, so you might not get the color change with them. And if you have gastric acid that came up as they aspirated and it gets stuck on that stuff, it'll also inhibit the color change, because this is basically just litmus paper in there, and so if you pour acid on it, it's not going to change color anymore. Another thing that you can use is an esophageal detector device. And what this is, it's like a giant bulb that sits on top of your ET tube, and you squeeze all the air out of it. You hook it up to this ET tube. So if you squish all the air out of it, and then you let go, and this thing is in the esophagus is very pliable. It's going to be squished around the end of this tube, and so air isn't going to get in here. So this thing is not going to reinflate. So if you squish it closed and it doesn't inflate, you're in the esophagus. If you're in the trachea, those tracheal rings are going to hold it open, and so when you squish it closed, air can get through here, through that stented open trachea, and open this thing and reinflate this bulb. So if it stays squished, esophagus. If it inflates, it's in the trachea. And then the final device we should talk about is the one that they really recommend, and that is continuous waveform capnography. And what this does is it takes a reading of the CO2 that is exposed to. And in a normal person, this is going to go up to like 25 or 35 when they're intubated. Now, in a code, what's going to happen? You're not going to be ventilating the lungs so well, so you might only go up to 10. But that's what you know. When you see this waveform, you say, hey, I gotta be in the trachea because I'm seeing this waveform here with chest compressions. I'm doing something. So this only goes up to 10. Okay? And that's when you're in a code. And like in a normal person, we'll say this one goes up to 35. This is pretty darn good to confirm intubation. It's not perfect, but it's pretty darn good. And the other benefit of this is it'll also help you know when the code is done, when you reestablished, when the patient's got a heartbeat again, what we call return of spontaneous circulation. What happens then is you get more CO2 being produced because their heart is beating properly again. Then you're back. What we previously had to do without waveform capnography is we'd have to stop chest compressions and then check a rhythm, feel a pulse. Now we know that we're really stressing continuous CPR. Stopping to check a pulse is not recommended. So that's why this continuous waveform capnography is great. Then let me just talk about one more thing. What rate should you be ventilating these guys at? They've done studies where they've watched people bag people in a code, and people will bag at like 60 breaths per minute. And that's obviously way too fast. Nobody breathes that fast. So you don't want to do that. If you can aim for 6 to 10 breaths per minute, or rather than watching the clock, when you take a breath, give them a breath. And that way you're breathing them at a normal rate. And I'm going to give you a little caveat to that. If your patient is sick, let's say they're septic and they're acidotic, and they have a respiratory compensation, and so they're breathing really fast to try to get rid of some of that acid, and then you intubate them, and then you ventilate them at 6 times a minute. What you've done is taken away their respiratory compensation. So what's going to happen? They were breathing fast to get rid of acid, and now you've taken that away from them. They're going to become profoundly acidotic, and so that's going to make them code if they weren't already. So in the patient who's pretty tachypnic from the start, I try to set the rate at whatever they were before I intubated them. So maybe they're breathing 30 times a minute, but shallow. I'll say, fine, I'm going to breathe them at 20 times a minute, because I know that my bags, the volume I'm going to give by the bag or the ventilator is going to be a little bit more than what they were getting on their own. Okay, and that's it for Airway.